This voiceover PowerPoint is in regards to digestive, GI, and metabolic function with regards to assessment and diagnostics. When looking at nursing assessment regarding the GI system, there's just a few things we need to include that maybe we don't include in your average assessment, but we need to look for and ask about the following: abdominal pain, dyspepsia, or what we consider indigestion, gas, so flatus, belching, any problems with that, any problems or history with nausea and vomiting, constipation, diarrhea, bowel patterns, normal bowel patterns, and any change in bowel patterns, characteristics of the stool, history of any GI surgeries or GI problems, history of appetite or eating disorders or eating patterns, good assessment of their dentition or teeth, and a nutritional assessment that includes weight patterns, whether they've had recent weight loss or weight gain. We also need to consider psychosocial, spiritual, and cultural factors that might affect a patient's nutrition or eating. We also need to think about lifestyle factors such as use of any tobacco or alcohol, and if so, the types, amounts, and lengths of use, and if a history of use, the discontinuation date of that use. Gerontological considerations regarding the GI system, oral cavity, and pharynx. So we need to think about teeth decaying or loss. Taste buds do atrophy, and there is decreased salivation. Within the esophagus, there's decreased motility and emptying. Sometimes they have a weakened gag reflex. With regards to stomach, there's atrophy of the gastric mucosal surfaces, decreased production of hydrochloric acid, and decreased production of digestive enzymes, decreased motility and emptying. And with regards to the intestines, muscle and mucosal atrophy, the elastic wall of the large intestine and tone of the sphincters decreases. We need to monitor for signs and symptoms such as difficulty chewing or swallowing, gastric reflux or heartburn, any difficulties with dysphagia or dyspepsia, food intolerances, malabsorption problems, and again, decreased gastric motility is an age-related change, so any motility problems with their bowels. With regards to that slow or low motility, we need to watch for problems with indigestion and constipation, and consider educating on factors such as that. And the loss of sphincter control, we need to consider fecal incontinence. Common clinical manifestations with regards to GI function, pain, and it could be pain associated with abdominal pain. We need to remember what our assessment of pain is, such as character, duration, pattern, frequency, location, referred pain, time of pain. Is it constant? Is it intermediate? Is it related to anything such as meals, resting, activity, or defecation? Dyspepsia, which is discomfort with eating, and what causes that discomfort with eating. Fatty foods are often a cause. Highly seasoned foods can also be a cause, but we need to find out what the cause is for that patient. Intestinal gas, so whether it be resulting in belching or flatus, which is gas expulsion through the rectum, and some foods may cause that. And we need to figure out what causes that with our patient. Nausea and vomiting, again, causes and treatment. Nausea is something that, as a nurse, you need to intervene with quickly because we want to prevent the vomiting portion of that. Vomiting can put patients at risk for fluid volume deficit, aspiration, malnutrition. So nausea needs to be considered very serious and intervene at the soonest possible moment. Changes in bowel habits, so that could signal considerable things such as GI disorders and or cancers. Diarrhea and constipation fall within the change of bowel habits. So get a really good history of the patient and what their normal habits are and what their habits are now, like frequency, and what their stools normally look like. Changes in stool characteristics. So stool is normally light to dark brown and formed. Alterations or some changes we could see would be greasy or foamy stools, foul smelling, and remember the greasy stools are steatorrhea. Light gray or clay colored stools, absence of bilirubin, stools with mucosa or mucus or mucus threads or pus in them, rock hard stools, loose watery stools, black tarry stools, remember upper GI bleeding, or bright red stools in regards to lower GI bleeding, and any changes. So what are their normal stool habits and characteristics, and then what are the changes that are noticed. This physical assessment landmarks slide is available to you just to get you to have an understanding of where things are. I know in our disorders slide we talk about a lot about where pain is, right upper quadrant, right lower quadrant, etc. And so this is to give you a good idea of landmarks and what is located in those quadrants. Assessment or examination of the abdomen. We need to start with inspection and then move to auscultation, and then percussing and palpating are last. Needing to know the order of that. So as noted in your text, inspection is first, auscultation is second, percussing is third, and palpating is fourth. With regards to percussion, they are listening for a dullness or solid. Dullness reflects a solid, and tympany reflects air. So are they looking for something and listening for air-filled, fluid-filled, or a mass? We need to, during the auscultation, listen for clicks and gurgles. Bowel sounds usually range from every 5 to 34 seconds. Hypoactive bowel sounds is 1 or 2 sounds in 2 minutes. Hyperactive is 5 to 6 sounds in less than 30 seconds. And absent is none in 3 to 5 minutes in each quadrant. So you need to listen to each quadrant for 3 to 5 minutes to be able to say that they are truly absent bowel sounds. With regards to the summary of the assessment of the nursing assessment of the abdomen. Inspection, we're looking at their skin, we're looking for pulsations, we're looking for any contours, we're looking for peristalsis, rippling waves, we're looking for any abdominal aortic pulsations that could be seen. Regards to auscultation, we just discussed that. Bowel sounds in 4 quadrants. Beginning with the right lower quadrant, moving to the right upper, then the left upper, then the left lower, and that's the direction we would listen. Percussing we've discussed, and palpating lightly for tenderness, for masses, and for rigidity. There's our landmarks, our quadrants. This slide shows you the differences between some things we might see with regards to abdominal assessment. Upper left is ascites, upper right is obesity, and then the bottom is a bulging hernia. With regards to ascites or certain disorders, we do want to measure abdominal girth. If there's any abdominal distension, we need to see if there's growth in that. So by measuring the abdominal girth, we can tell if there's like active bleeding or any type of growth with that distension. Palpation, which we discussed, but more specifically checking for rebound tenderness, used when abdominal pain or tenderness is found on assessment. Hold hand at a 90-degree angle, push in slowly and deeply, lift quickly. A normal response would be no pain on release of the pressure. A positive response would be pain on release of the pressure, and then we would note that in our physical exam. Diagnostic studies, as far as lab studies, CBC, and we're checking for several things. I know we're doing an activity in class, and you'll get some more information on a diagnostic form that we will be providing to you. But just knowing that within the CBC, we're probably looking mainly at the hemoglobin and hematocrit, noting for any bleeding, platelets and the ability to clot, and white blood cells, which are in regards to infection. With regards to the chemistry, of course, we're looking for electrolyte disorders from any maybe fluid volume problems. Amylase and lipase. So amylase is for digesting carbs, and it is an enzyme that breaks down starches. Lipase is a protein, and it helps break down fats. Now, with regards to the CBC and the chem profile, patient does not have to be NPO, but with regards to the amylase and lipase testing, they do need to be fasting for 8 hours, so no food and drinks for 8 hours. Diagnostic evaluation in regards to stool testing. Several tests that can be done on stools. You can check for ovum parasites, fecal leukocytes, and then we can also check for fecal occult blood. Most common tests to screen for disorders. Bleeding that would cause bleeding in the GI tract. Need to send the specimens immediately after collecting. Sometimes patients can collect this specimen at home and bring it into the office. They usually collect 3, and it's usually over 3 days. And when they do collect it, it's never like from the same area of the stool. So if they did collect 2 at the same time, it would have to be different areas of the stool. Things to consider: patients should not eat red meats, take aspirins, anti-inflammatory drugs, ingest turnips or horseradish. All of these things can give a false positive to the testing. And bleeding hemorrhoids also give a false positive. With regards to abdominal ultrasound or ultrasonography, it's not a painful procedure. There's no radiation, no side effects. They're just mainly watching the frequency of the sound waves to get a picture of what's happening in the abdominal area. One important thing, though, is that they need to go in with an empty bladder to give them a full pelvic view. So the bladder needs to be empty. Some more preparation as far as the abdominal ultrasound. They should fast for 8 to 12 hours before the test, and that decreases gas in the bowel area. And DNA testing is a self-study section. Regarding CAT scans and MRIs, so a couple things. CAT scan, it provides cross-sectional images of abdominal organs, or any organs for all that matters, but right now we're talking about GI. It can be performed with and without contrast. You need to definitely make sure you have a BUN and creatinine to assess for renal function. before providing the patient with contrast. And that would be up to the physician. And then there are some things you can do if the patient's BUN and creatinine are on the slightly high level and the physician still wants contrast. They can give some medications to help with that. One of them is mucimist before the procedure orally, and that helps the kidneys or renals flush the contrast out. So not absorb the contrast. It does help to get rid of the contrast. With regards to the CAT scan, need to check for any allergies to shellfish and iodine because of the contrast, and often they are NPO 8 to 12 hours before the procedure. The MRI, which I think we've talked about in the past, but we'll talk about again. We need to make sure that there are several questions that have to be asked of the patient, and there's a form that they usually have to fill out before having an MRI. But we need to make sure there are no metal objects, no jewelry, no recent plates placed or work done on internally or externally on the body with regards to metal. We need to make sure any transdermal drug patches with foil backings are off. So no metal whatsoever. So all metal must be removed. Patient needs to be NPO for 6 to 8 hours before the study. Study can take up to 60 to 90 minutes. If they're claustrophobic or extremely anxious, they may require some medication to help calm them down beforehand, because it really is a very small space, and they will hear some loud knocking sounds during testing. And oftentimes the facility will try to give them headphones to help decrease on that knocking sound that they're hearing. With regards to endoscopic procedures, patient is NPO 8 to 12 hours before the procedure. This is an EGD or esophagastroduodenoscopy or EGD. They may require some sedative, and it's usually moderate or what we call conscious sedation. So they'll give them something to help them forget it, like Ver said, and then something to help control the pain. So pain med and the forgetful med. Patient's airway needs to be maintained at all times during and after the procedure. After the procedure, the nurse needs to monitor for return of the gag reflex before the patient can intake anything. So that's a big thing, is to check for that return of gag reflex. Need to monitor O2 sats continuously during the procedure. So this is a visual study, but they can also, while they're down doing the esophagogastroduodenoscopy, they can also do biopsies if there's suspicious areas and they want to check for any type of possible cancer or dysplasia noted in the esophagus area. Colonoscopy or sigmoidoscopy. Few things to remember here. They're on a clear liquid diet the day before. They usually give laxatives the night before. One of the preparations is called Go Lightly, which makes you go heavily. But they want the bowel empty and clear, so bowel movements should be totally clear when they have this procedure. You need to be cautious with bowel preps for elderly. This can be quite difficult, one, getting to and from the bathroom to get them emptied, and they can be at greater risk for fluid and electrolyte imbalances. So anyways, clear liquid diet first, then their NPO 8 to 12 hours before the procedure. They'll visualize the lower gastrointestinal tract. They do also have the ability to remove polyps while they're in there. Again, like the EGD, this is under conscious or what we call moderate sedation. Patient's left side lying with the knees towards the chest for this procedure. The big thing to remember when they return is that we assess for bowel sounds and return of flatus and or having a bowel movement. We need to also monitor fluid and electrolytes because they have been on this fluid restriction and because of the bowel prep, so they're at great risk for fluid and electrolyte imbalances. And the other thing I forgot to mention is before the test, they need to stop NSAIDs and aspirin and iron. Another thing I want to discuss briefly, well, there are a few more items at the end of this PowerPoint that we need to be discussing. Laparoscopic, there is a small section of in your book on laparoscopic procedure. This is done under general anesthesia. It's used to visualize the peritoneal cavity. They do implement or ingest or put in a gas, so it's carbon dioxide, into the peritoneal cavity, and this helps to it helps for space visualization, so they can visualize the peritoneal cavity better. Patient's NPO 8 to 12 hours before. Patient does need a consent because it is an invasive procedure. Think peri-op, so those perioperative chapters before, during, and after surgery, because this is a surgery. We need to also afterwards assess their abdomen. They will have some bloating in the abdominal area because of the gas, and that does cause some pretty severe shoulder pain. And if we can get them up and walking, ambulating early, that helps to take care of that. Think about much like our post-op considerations, so when to call the physician. They've got those laparoscopic sites, so we need to monitor those for infection. We need to monitor for bleeding, infection, whether it's the sites or fever or elevated white blood cell count. So those are things to consider. A few more things from this chapter to review are the following. You need to review the breath tests, the hydrogen breath test and the urea breath test. Urea breath test used for detecting H. pylori, and considering when you're reviewing these breath tests, the any preparation needed. For example, for the urea breath test, they need to avoid antibiotics or Pepto-Bismol for a month prior to the testing. So consider those factors when studying these sections. We need to also review upper GI series and lower GI, the barium studies. So for the upper GI series, it's used definitely to, if they have heartburn or reflux problems, they'll drink barium and do an x-ray. Should not be a painful procedure. It's called an upper GI fluoroscopy scan. They'll watch the barium move through and detect any tumors or ulcers or strictures. They are NPO 6 to 8 hours before this procedure. Procedure takes about an hour. And then afterwards, we need to encourage them to drink a lot of fluids, a lot of water, because we want them to pass that barium through their stools. So we need to watch for white pasty stools, and that would be a good thing because that means the barium is leaving their body. The lower GI or barium enema, they need to eat a low residue diet 1 to 2 days before as a preparation for this barium enema. They'll have a laxative the evening before. There'll be NPO the evening before. They will definitely afterwards have the milky white stools. Sometimes the stools will be really large and wide, but we should not be seeing any blood streaks post barium enema. But again, important thing is that they get the barium out. Another item to review is the gastric analysis section and the pH monitoring. This is the conclusion of the assessment and diagnostics PowerPoint. And again, we're going to work a lot on diagnostics within the classroom setting. Thank you.